So good evening to everyone, and thank you for inviting me to participate in this event. And today's topic is imaging of progression in multiple sclerosis. These are my disclosures that I think will have no impact on the content of my presentation. We all know that MRI is the most important paraclinical tool that we have nowadays, not only for making an early and accurate diagnosis of MS, not only for monitoring and predicting treatment response, but also the findings that we can obtain with this technique help us to predict disability worsening and conversion to secondary progressive phenotype. This is because MRI is highly sensitive for detecting the typical white matter lesions that characterize this disease. It's a little bit more difficult to identify the cortical lesions that, as we will see, also contribute to predict the prognosis of the disease. But a classical concept that has been described many, many years ago is that there is a disconnection between the amount of lesions that involve the brain and the variation in disability. And this is taken from this old paper from Frederick Barkov. And you can see that the T2 lesion load explains just a minority of the changes that occurs in disability in these patients. So we will try now to identify different measures that in conjunction could help us in predicting the course of the disease. This is a recent paper published just 1 or 2 years ago by Rostein and Montalban, and it's a nice and interesting review paper in which they analyze different factors that contribute to the prognosis of the disease. There are demographic and environmental factors. There are clinical factors that are extremely important. Some biomarkers that also have been described recently that also contributes to predict the prognosis, in particularly the presence of IgM oligoclonal bands, or more recently, the presence of neurofilaments. But obviously, the topic for today is the contribution of MRI. And in this paper, they mention several factors, such as the number and volume of the T2 lesions, the presence of gut lesions, and the topography of the lesions, and also the degree of brain atrophy. So let's start by the simplest way to predict in some way the prognosis of the disease, particularly in patients with a clinical isolated syndrome. This is a paper that we published 5 or 6 years ago, in which we collect more than 1,000 patients with a clinically isolated syndrome. We follow them for around 7 years, and we analyze very simple clinical, demographic, and radiological measures. And the major contributor to predict those patients who will have a progression in disability reaching an EDSS score of 3 or more is simply the number of T2 lesions at the initial brain MRI. And the threshold that better discriminate between patients with a poor or a better outcome was the number of 10 lesions. So if you have a patient with a clinical isolated syndrome, you identify at least 10 typical lesions in the brain. This indicates a higher risk of progression in the coming years. But not only the number, also the topography of the lesions contribute to predict this disability progression. And in a specific area is the brainstem or the infratentorial compartment, but in particularly the brainstem. And this study that also included more than 240 patients, also published in our institution, we could demonstrate that the presence of at least one infratentorial lesions, as you can see in this graph, also identifies patients with a higher risk of reaching this degree of disability. The same kind of study was performed in which we analyzed the spinal cord topography, and also this topography contributes to predict disability progression, particularly if these lesions, such as the ones that you see in these images, are asymptomatic. And this have a clear impact in our clinical practice, in the sense that in patients with a clinically isolated syndrome, even if the symptoms are not related to the spinal cord, it's important to perform a baseline spinal cord MRI, because the identification of lesions help us in predicting the prognosis, and also can serve as a baseline examination in which you can use in the future for comparison when you need or is required to repeat this spinal cord image. Another area which is highly eloquent in relation to the prognosis of MS is the cortical gray matter. We know that in the progressive phases of the disease, the extension of cortical demyelination is even higher compared to the white matter demyelination. But in the early phases of the disease, and this is these drawings are taken from this paper from Kulzerning, even in the early phases, you can see areas of cortical demyelination. And this is extremely important, because when you identify these type of lesions and you count these lesions, the presence and number of these lesions also predict the risk of clinical isolated syndrome patients that will evolve, will convert into a secondary progressive MS phenotype in the next years. The problem with these cortical lesions is that are not easy to identify. We need a special sequences, such as these two ones that I'm showing here. This is a heavily T1 weighted sequence called phase sensitive inversion recovery. And this is a double inversion recovery. And you can see that in combination, you can nicely identify this cortical lesion in the post-central region of the left hemisphere. So if you are interested in identifying this type of lesions, you have to perform special sequences. With the conventional ones, it's very, very difficult to identify them. So cortical damage is extremely important, and we know that from many papers. And in fact, the group of Calabrese in Italy, they recently created a kind of a prognostic score to assess the risk of progression into a secondary progressive MS phenotype. They included a relatively large number of patients with MS with relapsing forms, followed for 10 years. And what they found is, I will not go into much detail about this score that has been recently published in the European Journal of Neurology, but the cortical damage, meaning the number of cortical lesions, the atrophy of the cortical gray matter, the cerebellar cortical volume, all these measures together with the age of the patient contributes to predict the risk of conversion into a secondary progressive MS phenotype. Also, the group from Queen Square in London proposed this model in which they combine findings, MRI findings from the brain and from the spinal cord. And they could demonstrate that the presence of at least 2 gadolinium enhancing lesions or at least 1 spinal cord lesions predict in an independent way the risk of conversion to a secondary progressive MS phenotype after 15 years. So the combination of both brain and spinal cord findings are extremely important in order to predict this progression. Also, in this study, they analyze changes that occurs within the first 3 years after the onset of the disease. And they could demonstrate also that the presence of new lesions in the spinal cord or in the brainstem also are good predictors of conversion into a secondary progressive MS phenotype. The meaning of that is that it's extremely important to assess patients with a clinical isolated syndrome with early relapsing remitting phase with both brain and spinal cord, meaning within the first years in particularly, because this could provide important information that could have an impact in the management of the patients. Another way to identify patients with a risk of progression is to analyze the volume of the T2 lesions. I know that this is something that we usually do not perform in clinical practice. It takes some time, but this is a classical study also from the London group in Queen Square. And what they did is to analyze the changes in T2 lesion volume within the first years. And when you see a significant change, as you can see in this patient in the upper row, this also indicates a risk of early progression to SPMS. While if during the first years the volume of these T2 lesions remains quite stable, then indicates a lower risk of conversion. However, this is adequate, this measure, in the early phases of the disease. But we also know that when patients reach a certain degree of disability, such as demonstrated in this paper by Lee, when the patients reach, let's say, an EDSS scale number of 4.5, there is a plateau effect, meaning that usually the T2 lesion volume remains stable despite the patient show progression in disability. So there is a disconnection between T2 lesion volume and disability progression. And this can be explained by several factors, but one of them is the development of an acceleration of the neurodegenerative component of the disease. And in this example that I'm showing you here, in which we have the opportunity to follow a patient for more than 6 years, you can see that the T2 lesion volume remains stable, but there is an increase in the ventricular size indicating a development of brain atrophy, which is a marker of this neurodegenerative component of the disease. So it seems, according to these findings, that focal white matter pathology increases during the initial phases of the disease, and this contributes to predict disability progression, but then remains relatively stable. And in these later phases of the disease, it's important to use as imaging measures, measures that identify the neurodegenerative component of the disease, such as, for example, in this case, brain atrophy. Okay, so keep in mind that MS has two overlapping components, an inflammatory component and a neurodegenerative component. Both are closely linked at the early phases of the disease. So we have already neurodegeneration at the early phases of the disease, but when the disease progresses, these two components becomes in some way unlinked, and we have a lot of acceleration of this neurodegenerative component without the typical focal inflammatory events that characterize the early phases. There is inflammation, obviously, in the late phases of the disease, but it's a different type of inflammation. It's a more chronic inflammation that is linked to the neurodegenerative component. So also we know that the best way that we have to measure the neurodegenerative component is to assess the brain or the spinal cord volume as a markers of atrophy. So this is what we could do in clinical practice. This is a clinical case in which the patient was treated with different disease-modifying treatments with good response for several years, but because of safety concerns, for safety, the patient decided to stop the treatment, and you can see that there is an increase in the number and volume of the T2 lesion load. And you can see here the increase in the T2 lesion volume, load. But in addition to that, we can measure the brain volume, and then you can see that the brain volume was relatively stable during these years, but suddenly decreased. And this, according to many papers, indicates that this patient have a higher risk of developing cognitive decline and disability progression in the coming years. So this is something that we need to avoid, the development of this acceleration of brain atrophy. Okay, so let's start talking a little bit about brain atrophy as a marker of this neurodegenerative component. And we know that the degree of brain atrophy is different if we assess the white or the gray matter. It's more relevant from a clinical point of view to assess the gray matter component, because this accelerates over time. The white matter atrophy, it remains quite stable. And also, as we will see, the degree of gray matter atrophy better correlates with disability and cognitive decline. And as you can see in this classical paper from Fisher, gray matter atrophy better discriminates the different phenotypes of the disease, while this is not the case when we assess the white matter. So focus more on the gray matter atrophy in MS. But gray matter means cortical gray matter and deep gray matter. And this is a study performed within the Magnims network in Europe, in which we analyze more than 1,200 patients, 400 patients, sorry. And we analyze with different phenotypes, we analyze the degree of atrophy, cortical atrophy, white matter, deep gray matter. And we could demonstrate that the main driver of disability worsening is the loss of deep gray matter volume, and particularly the thalamus. And fortunately, nowadays, we have different automated tools that help us in assessing the degree of deep gray matter volume, as you can see here with different basal ganglia and also the thalamus. So thalami plays a very important role even in the early phases of the disease to predict disability progression. So what we should do in order to create models that predict this progression. So particularly in the early phases of the disease, to combine the presence of new T2 lesions, focal lesions that reflects the inflammatory focal events, together with the progression of atrophy in these early phases of the disease. The combination of these two measures really, as demonstrated in this also Magnims paper by Popescu, predicts disability progression in the next 10 years. So, and this is an example of a patient. This is the baseline examination. You see that the patient developed new T2 lesions and also developed atrophy that can be seen as an enlargement of the lateral ventricles. And even nowadays, now is a hot topic, artificial intelligence, and how can we use them in order to create models for diagnosis, for monitoring, for establishing the prognosis. And it's interesting that in this model that was also recently published, they combine two very simple measures, the T2 lesion load and the thalamic volume. And these two measures combined with demographic and some clinical factors also predicts the disability progression in MS. And this is important because in these models, we don't need to perform any non-conventional MRI technique, such as diffusion tensor imaging, functional imaging. Is based exclusively on conventional imaging, T1 for assessing the degree of atrophy, and T2 for detecting the T2 lesion load. And this has been also observed in this also very recent paper in which they collect patients with a relapsing remitting MS phenotype, and they assess the degree of brain and spinal cord atrophy, and they could demonstrate that the degree of regional atrophy within the first years after the onset of the disease predicts progression or even related death 25 years later. So you can see in these graphs how patients, the EDCS progression depending on the phenotype, and how this correlate with the volume loss at the level of the brain and also of the spinal cord. So we introduce here another structure which is clinically relevant, even in the early phases, such as the spinal cord atrophy. However, when we try to replicate these models in patients with a secondary progressive MS phenotype, and we try to predict how these patients will evolve over time, these models of brain atrophy, global atrophy, they don't work very well. And this is another recent paper in which the association of a standard conventional MRI measures and disability was quite weak. And the explanation of this discrepancy between MRI findings and disability progression is because in this particular paper, they did not analyze in detail, for example, the thalamic volume or the spinal cord volume. So in the progressive phases of the disease, we have to work a little bit more on the deep gray matter structures and in the spinal cord in order to create these prognostic models. The good news nowadays is that we have tools that analyze the measures that I mentioned you before. For example, the T2 lesion load. This is an example. This is a T2 FLAIR image. We can analyze automatically the T2 lesion load, and also we can analyze the volume. In this case, both the gray and the white matter volume. So these are measures that we've been using for many years, but for research studies, the difficulty is to implement these measures in clinical practice. This is something a little bit more difficult. But now we have tools. Some of them are commercial. Some of them are already available by the different MRI vendors, so easy to implement and to use in clinical practice. This is one of the tools, and in which, for example, we perform 2 examinations at different time points. Obviously, we need to obtain these sequences, these images, with a standardized MRI protocol from a technical point of view. And with these tools, we can analyze the T2 lesion load, the presence of new T2 lesions, and also we can analyze the degree of global and regional brain atrophy and how this atrophy evolves over time. This patient was relatively stable with almost no changes over time. So we have tools that are easily implemented, can be easily implemented in clinical practice and easily used. But I already mentioned before the relevance of spinal cord atrophy, not only in the early phases of the disease, but particularly in the progressive phases of the disease. The way to analyze the degree of spinal cord atrophy is based on the acquisition of a high resolution 3D T1 weighted sequence. With this sequence, we can analyze the cord cross-sectional area, which is also a marker of atrophy. And we usually measure this at the upper segment of the cervical segment. And also we have tools that automatically assess the degree of this spinal cord atrophy. And this is an advantage of these tools, is that we can assess the degree of spinal cord atrophy without the need to perform a specific sequence of the spinal cord. Because usually when we scan the brain, we also scan the upper segment of the cervical cord. And therefore we can analyze using a brain MR acquisition the degree of atrophy of this upper segment of the spinal cord. This is an example. These are 2 acquisitions from a brain acquisition in a patient with MS. And you can see that we can identify and calculate the degree of atrophy of the spinal cord using this brain MRI. So we don't need to expand to scan the patient back or again to scan the spinal cord. The advantage of using the spinal cord as a marker of the neurodegenerative component of the disease is because the degree of spinal cord changes over time is much higher compared to the changes that occur in the brain. In the brain, in MS patients, we expect an annual change of around 0.3 to 0.6 per year. But according to this systematic analysis published a few years ago, the degree of spinal cord atrophy per year is about 1.8% per year. So this means that it's a little bit easy to identify changes over time, because the expected change is higher in the spinal cord compared to the brain. However, the bad news is that up to now, according to data coming from different clinical trials, most of them performed in progressive MS patients, none of the drugs that have been tested in these clinical trials have demonstrated any beneficial effect in preventing the development of spinal cord atrophy. So this means that maybe we are not still enough sensitive to detect small changes in the degree of spinal cord atrophy, or I think that the most likely explanation is that these drugs, they don't have a real neuroprotective effect in the spinal cord atrophy. But anyway, I think that the message here is that it's clear that there is an acceleration in the disease course of gray matter pathology that explains the neurodegenerative component, the disability progression, cognitive decline. And if you are interested in using these measures, I think that you have to focus on the gray matter, particularly in the deep gray matter volume, or in the spinal cord, because also it has been demonstrated by the Milan group that there is an acceleration of the degree of spinal cord atrophy in those patients who show disability progression. Also related to atrophy, I would like to introduce a relatively new concept. In this case, a concept that we were aware many years ago, but we didn't really explain it. But the group of Sibadinov in the US published this paper that introduced the concept of a T2 lesion volume atrophy. What does it mean? It means that in some patients, particularly in progressive patients, when you follow them with MRI, there is a paradoxical decrease in the degree of, in the extension of the T2 lesion, in the volume of the T2 lesions. And this is an example from the paper from this group. This is the baseline examination performed in a patient with a secondary progressive MS phenotype, and this is the follow-up. So you should expect an increase in the T2 lesion volume, but in fact, there is a decrease. And this can be explained by the development of severe atrophy of these areas that are heavily demyelinated and with axonal loss. And in fact, if you look carefully, this atrophy of the T2 lesion volume is associated with an increase in the ventricular size. So there is a correlation. You lose tissue, and then you have an increase in the ventricular volume. And these both measures explain in some way the progression of disability. And this atrophy of the T2 lesion is more evident in the progressive MS phenotypes compared to the relapsing remitting phenotypes. And what is important from a clinical point of view, and this is another paper from the same group in which they include a relatively large number of patients, and they could demonstrate that the degree of brain atrophy, of T2 lesion atrophy was associated with disability progression and with conversion to secondary progressive MS phenotype. So this is an example from my own institution. This is a baseline examination. This is a follow-up after 6 years. The patient had a clear progression in disability. And again, if you look carefully, it seems that the T2 lesion volume has been decreased in association with an increase in the ventricular system. So also this supports the concept that the assessment of T2 lesion volume is not a good marker of disease progression, mainly in the progressive phases of the disease. So I would like now to talk a little bit about some emerging MRI features that have been described in the last few years that seem that also could contribute to predict the prognosis of the disease. We need still more evidence, but I think it's important that you get familiar with these recent described MRI features. And the first one is the so-called leptomeningeal enhancement. For many years, we thought that there was no leptomeningeal enhancement with MRI in MS. This is more typical for other disorders such as vasculitis, such as infectious disorders, and other types of inflammatory disorders. But it has been shown that leptomeningeal enhancement, as you can see in this image, is relatively frequent in MS. And this is a reflection of the presence of the so-called leptomeningeal infiltrates. So we know that this is something described many years ago, that mainly in the progressive MS forms, we can see these infiltrates of T cells and B cells, mainly B cells, that occupies the deep portion of the cortical sulci. And these infiltrates are not visible with MRI, but we can see the consequence of these infiltrates. And the consequence is that this produces an increase in the permeability of the leptomeningeal vessels. So keep in mind, you have these inflammatory infiltrates that even forms a kind of B cell follicles. It seems that these infiltrates contribute to gray matter pathology, both gray matter atrophy and subpial demyelination. The presence of these inflammatory infiltrates seems to be associated with a more aggressive disease course, and as I mentioned before, is associated with leptomeningeal enhancement. However, we are usually, when we want to identify enhancement with MRI, what we do is to perform a contrast-enhanced T1 weighted sequence. But for this leptomeningeal enhancement, this sequence is not sensitive. We need to obtain a contrast-enhanced T2 flare sequence, because we know that this sequence is highly sensitive for detecting any type of meningeal pathology, inflammatory, neoplastic, whatever. So this happens the same with MS. And you can see nicely this area of leptomeningeal enhancement in the Sylvian fissure, not seen with the contrast-enhanced T1 weighted sequence, and not seen obviously on the unenhanced T2 weighted sequence. So if you are interested in identifying this type of leptomeningeal enhancement, please perform the T2 flare sequence after the injection of gadolinium. And in fact, whenever we use gadolinium in our clinical practice, we always obtain the T2 flare after the injection, not before, in order to be able to identify these areas of leptomeningeal enhancement. Also, it has been shown that this leptomeningeal enhancement persists over time. So it doesn't disappear, as happens with the focal gadolinium enhancing lesions in the white matter, because this is a chronic type of inflammation. And it has been also shown that the number of persisting foci of leptomeningeal enhancement is associated with a progression in disability, because it's associated with cortical damage. Again, the cortical gray matter is extremely important from a clinical point of view. Other emerging features are related to the white matter lesions that we identify quite easily with T2 weighted sequences. And I will talk very briefly about the paramagnetic rim or the peripheral rim and the concept of slowly expanding lesions. So in order to identify these paramagnetic rims that I will explain a little bit more in detail, we need to perform a specific sequence, the so-called susceptibility weighted imaging. This is a sequence that is highly sensitive to the paramagnetic properties of certain substances or elements, such as iron. In this case, we use this sequence to identify iron at the margins of some chronic demyelinating lesions. And this is an example. This is a patient with an early relapsing remitting MS. This is the T2 flare, a lot of lesions. And then when we obtain this SWI sequence, we can see that some of the lesions, not all the lesions, show this paramagnetic hypointense rim that seems to reflect iron inside the macrophages and activated microglia, and therefore, as we will see, a marker of chronic inflammation. So this is a multi-center study performed in the US. They included more than 430 patients coming from different centers. They used this technique in order to identify these paramagnetic rims, and they could identify at least one of these rims in around 50 to 60% of all MS patients, with no difference between the clinical phenotypes. While this finding is less frequent in other neurological disorders. So the presence of these rims have diagnostic value to make a correct differential diagnosis with other conditions. But now I am interested in the value of these rims in predicting disability progression. And they could also demonstrate that the presence and number of these rims are associated with disability in patients with MS. This is also from a group in the US, and they also assess the presence of these paramagnetic rims, and they count the rims, and they also establish a significant correlation, not only with disability, but also with cognitive decline. So has relevance from a clinical point of view. Remember that these rims reflect these chronic inflammatory infiltrates by macrophages, by microglia in the surroundings, in the outer margin of chronic demyelinating lesions that are called now chronic active lesions. So this is a summary of these hypointense rims. They are not permanent. They slowly disappear over time. It takes some years to disappear. Then the lesions become completely inactive. There is no inflammation at all. They, as mentioned, correlate with disability, predict disability progression. And it's a very interesting finding because these rims of inflammatory reaction could be the target of new therapies against this innate inflammatory reaction. But also this finding, this radiological finding seems to be to correlate with a concept described by the pathologists. I already mentioned these chronic active lesions or slowly expanding lesions or smoldering lesions. The correlation is not perfect because still we can see some of these lesions without iron at all, or even we can see iron or paramagnetic rims in some lesions that are chronic and inactive. So the correlation is not perfect, but we can consider that these rims as a marker of this inflammatory activity. Again, this is an example. We can see a nice lesion in the periventricular anterior white matter, and this is the SWI. You can see how we can see this hypointense rim that reflects iron inside inflammatory cells. But this also led us to introduce another emerging MRI finding, a new concept, the concept of slowly expanding lesions. This concept has been used by the pathologists for many years, but now with MRI, we can also identify a subgroup of chronic lesions that show local expansion. You can see this is a baseline examination. You see the lesion here, and then after a couple of years, this lesion grows. And despite there is no gadolinium uptake, so this is not a kind of a reactivation of a lesion with B cells or T cells, but in this case, this reflects the presence of these chronic inflammatory cells, macrophages, and microglia that produce ongoing tissue destruction and expansion of the lesion. So this expansion reflects chronic tissue loss in the absence of ongoing acute inflammation, is in relation to chronic inflammation. And this is exactly what the pathologists described also many, many years ago. So the thing is that now we have two radiological features. One is the paramagnetic rim iron, and then the slowly expanding lesion. So the question is, are these two markers the same markers for chronic active lesions? And this is a nice study also performed in the US. They try to correlate the presence of rims with local expansion of the lesions, and they could demonstrate it after a follow-up of 3.5 years that the lesions that show rims of iron, such as you can see here, also increase in size after this period of time. And also they could demonstrate in this pathological and radiological correlation that these hypo-intense rims reflect the presence of iron. This is an example of a positive rim. This is a negative rim, no iron at the margins of the lesion. And also they could demonstrate that those lesions that are rim, they have a rim, they have a significant growth over time, while those lesions that are rimless, they usually are stable because there are no more inflammation that produce ongoing tissue destruction. This association between growing of the lesions and presence of the paramagnetic rims have been also demonstrated in this larger study that include almost 200 patients. And again, rimless lesions have a tendency to shrink over time, while those lesions that are that they have a rim, they are stable or usually have a significant growth. They expand over time, indicating ongoing tissue destruction that seems to correlate and predict disability progression, cognitive decline, and also a higher degree of brain atrophy. So this is a new marker that maybe, I'm not saying that we can use this marker in clinical practice, but probably could be considered a good marker in clinical trials that try to target this chronic inflammation in order to prevent disability progression. So again, this is the same example as I showed you before. This is the lesion. It grew after 2 years, and as expected, this lesion had this paramagnetic rim indicating iron inside inflammatory cells. Okay, I think it's time to finish. I would like just to mention that we have a lot of, I would say, non-conventional or advanced techniques that have been used for many years to identify microstructural changes that could explain disability progression, such as magnetization transfer, diffusion tensor imaging, spectroscopy, more recently T1 and T2 mapping, which is a little bit easier to implement, T2 relaxation maps, myelin water. But according to this recent paper, also from the Magnims group, all these tools are extremely useful to understand the physiopathology of MS, but we are far away to be able to use these tools in clinical practice. And this is something that we have to keep in mind. All these advanced tools are good for research, but not for clinical practice. The only, I think, measure that maybe could be used in the near future is myelin maps, a way to assess the concentration of myelin in the brain tissue. Up to now, this tool, this measure is very difficult to use in clinical practice because the acquisition of these maps is quite complex, the analysis, the post-processing. And although we know that these maps have a good correlation with myelin density according to different pathological studies, it's extremely difficult to use them in clinical practice. But nowadays we have some ways of creating synthetic myelin maps with using a very short acquisition time of around 5 minutes. We can obtain these maps quite easily, although this is a sequence that is not widely available. But in 5 minutes, you can obtain myelin maps that in this study published just 1 year ago in Annals of Neurology. I highly recommend to read this paper. It's a very good one. They could establish that these myelin maps also correlates with cognitive dysfunction and physical disability, and also predicts disability progression in patients with MS. So this is, I would say, an attractive tool, a promising way to predict the prognosis. So let me finish by saying that MRI plays a very important role in establishing the prognosis of MS, mainly at disease onset, not in isolation. Obviously, we need to also to consider demographic, clinical, and lab findings, and very simple measures such as one, as I mentioned you before, the number of lesions, the topography of the lesions, the increase in the number of lesions, brain atrophy, spinal cord atrophy, particularly if we assess the gray matter. All of these measures are useful. And then we have some emerging factors, such as the ones I mentioned, leptomeningeal enhancement, iron rims, slowly expanding lesions, maybe myelin maps, to use artificial intelligence in order to combine all these measures. And maybe in the future, we will have these models that when we see a patient for the first time in our clinic and we obtain an MR, we create these models, and then we can have relevant information that for sure we have an impact in the management of the patient, and also is a good way to explain the patient the risk that he or she will have a cognitive decline or disability progression in the coming years. So thank you very much for your attention. And these are the MS group in our hospital with basic research people, clinicians, and obviously also radiologists as myself, in which we work together trying to improve the care of MS patients. Thank you.
Thank you very much, Professor Alex, for this magnificent talk about this very recent important topic. I will start with, I guess this topic will raise so many questions, so I will start by actually few by myself. To start with, you know, the problem now is with the new treatment for the secondary progressive MS, we need to have a marker for the evidence of progression. And clinicians like me and also many others, actually, it's very difficult sometimes to define when this patient is starting to go into the progressive phase, especially that, you know, there is no sharp line. So probably MRI will play a very important role in the coming years as a biomarker for this. In your opinion, because, you know, it's, we tried, for example, the brain atrophy with different techniques, Sienna, NeuroQuant, and so on. And it wasn't very practical and it wasn't very standardized. And I don't know whether in your mind, what is the most likely coming in the few months or years biomarker? You said the myelin mapping, but I don't know whether, because maybe it's still in its infancy. I don't know whether it's this expanding lesions ring, the iron ring, the thalamic atrophy, the whatever you call it.
Yeah, so I have to say that unfortunately, we can use these measures to predict disability progression, but we cannot use any of these measures to discriminate between relapsed and remitting from progressive MS patients, because there is a lot of overlap in these measures. We know that in the progressive phases, there is an acceleration of the degree of spinal and brain atrophy, but we cannot use them to discriminate. And in fact, nowadays it's a hot topic to say that progression exists from the beginning of the disease, because we can identify atrophy from the beginning. So unfortunately, we cannot use MRI to make this differentiation. But in and when you consider a neurologist to treat a patient with a progressive phases, we also know that the drugs works much better if they have focal inflammation, and therefore in these patients, what we mainly do in order to recommend the treatment is to identify new T2 lesions compared to a previous scan, or to identify gadolinium-enhancing lesions. But in my opinion, the atrophy measures are especially useful in the early phases of the disease to predict the prognosis. And then maybe in patients with a certain degree of atrophy or an acceleration of atrophy at the early phases of the disease, this would indicate that you have to treat the patient with a higher efficacy drug, or maybe in the future with some neuroprotective agents. But once the patient enters a secondary progressive, you know that the patient will develop significant atrophy, but I think it's too late to do anything.
But don't you think, for example, leptomeningeal enhancement, which is, to my mind, it's an easy thing to be done, can guide us to choose new drugs which are working inside the brain? I mean, they can cross the blood-brain barrier and working in the second progressive phase. Because
but up to now, if I'm not wrong, all the drugs that are available, they don't have any impact on the leptomeningeal inflammatory infiltrates. I am aware that there are some new drugs that they could do that because they enter the CSF, but most of all the other drugs, and in fact, there is one study that tried to analyze the persistence of the leptomeningeal enhancement in patients treated with different disease-modifying treatments. And these treatments, they don't show any effect on this leptomeningeal infiltration. So I think that the leptomeningeal enhancement is useful when you see it in the early phases. And this is a kind of a warning, a message showing that, hey, this patient has a higher risk of disability progression and cognitive decline because these infiltrates produce cortical damage.
There's a question regarding the iron ring. You think we should use the quantitative QSM, quantitative susceptibility mapping technique, or we can use other techniques to visualize it?
Well, QSM is a sensitive technique. You can use it, but it's extremely complex to analyze this sequence. It takes some time. And in general, what we do, most of the groups from Europe, and also I'm aware that they do it in the US, they use a conventional SWI sequence. This is, you don't need to do any post-processing. It's very easy to read from a visual point of view, and you can identify the rims, and this is more than enough. If you're interested in quantifying the concentration of iron, then you need to do a QSM, a quantitative susceptibility mapping. But I think that we are still far from using this technique in clinical practice. It's a little bit complex to use it with different scanners. So I highly recommend to use a non-quantitative SWI imaging. And
SWI also will show you the central vein sign to prove the lesion.
Yeah, SWI, I don't want to go into much technical details, but depends on the field strength that you use. If you have a 3 Tesla or 1.5 Tesla, then you have to do a 3D echoplanar imaging, usually ideally with contrast administration if you're using a 1.5, but you can see the central vein easily with 1.5 or 3 Tesla, but the paramagnetic rims are really difficult to identify with 1.5 Tesla. It's better to use a 3 Tesla. So my recommendation from a diagnostic, or if you're interested in seeing the rims in a specific patient, in this case, you need to scan the patient with 3 Tesla. Not with the veins. The veins is enough with 1.5.
Okay. There's a question regarding the myelin mapping you mentioned, because you put it at the first one coming in the horizon. You think it's an easy technique to be done?
Well, if you use the classical ways to assess the myelin concentration in the brain, this is extremely complex from a technical point of view. That's why, although this technique has been described many, many years ago, we are not using it in clinical practice. But now there are 2 different ways in which you can obtain myelin maps very easily. But you need a specific sequence, and I don't know if you're familiar with the so-called synthetic MRI or fingerprinting. These are kind of sequences that create in in some way, in an artificial way, the myelin concentration. And the advantage is that you can quantify, and the sequence takes around 5 minutes. So it doesn't take too much long, and the post-processing is relatively easy. And there are several papers showing us, the one I show you from Annals of Neurology, that using this artificial way to create myelin maps, they could establish good correlations with cognitive decline and disability. So if you use these new techniques, I think that then these myelin maps is a promising technique, but not using the conventional way to acquire them.
Also, there is a question regarding the T2 lesion as a marker of progression regarding the decrease of the size of the lesion and the atrophy. This is done visually, or there is a quantitative way you can measure it?
Well, you can do it visually, but it's not robust enough. If you want to really analyze the degree of T2 lesion atrophy, you have to use some segmentation tools. So again, this is obviously a limitation to use this measure in clinical practice. But if you look at the papers that I showed you before from Sivadinov group, they explain how to measure this T2 lesion volume atrophy. I think that the message is not that we need to use this measure in our patients. I think I included this concept in order to understand why assessing the T2 lesion volume, the increase in the T2 lesion volume, is not a good marker of disease progression. And unfortunately, in many clinical trials, even in the progressive clinical trials, they use this measure. And as you can see, sometimes these measures show no effect of the drug of the versus placebo, any beneficial effect, because this is not a good measure. I think that in clinical practice, both in the progressive and in the relapsing phases of the disease, is much better to analyze the number of new T2 lesions, but not the total T2 lesion volume. It's not a good marker.
Actually, this is my question, because I'm very interested in the small vessel disease, which is quite common here in Egypt, and sometimes especially in the age group of 40s or below. It's of course sometimes confused with multiple sclerosis. Any apart from the classic description, of course, is the size of the lesion and the distribution. Anything specific? Maybe we can use, of course, the central vein sign, but anything specific for small vessel disease to guide you that this is a small vessel disease? And my second question is how to quantify it, because sometimes, like the MS, we would like, especially this form of small vessel disease, which is commonly seen in Egypt with what we call incidental small vessel disease. It's coming, progressing over years without evident stroke, and the patient finally will turn into a cognitive decline and difficulty in gait and so on. Anything of quantifying the progression of these white matter changes, whether it's software or...
Yeah. So the first question, how to make a differential diagnosis between a small vessel disease and MS, I think that in addition to some conventional or typical findings that I will not go into detail, you can identify microbleeds, which are common in a small vessel disease, not in MS. The second thing I will do is to scan the spinal cord, because we know that in a small vessel disease it's extremely rare to see lesions in the spinal cord, incidental lesions, asymptomatic lesions, while in MS, in established MS, more than 70% of the patients show spinal cord lesions, and most of them are asymptomatic. So even if we do that and still we have some doubts, I think that then is when you have to use these emerging features, the central vein sign, the paramagnetic rim sign, because we know that in a small vessel disease, we don't see these paramagnetic rims, and the proportion of lesions with a central vein in a small vessel disease is clearly lower than 20% of all the lesions, while in MS, depending on the technique you use, but always higher than 60, 70% of the lesions. So this is a way to make a discrimination using the central vein. I think it's relatively easy to use this sign when you perform a good technique. And I highly recommend also to look at the technical recommendations established by NAMES, this US network, that they publish some recommendations on how to scan the patients to identify the central vein. And regarding the quantification of a small vessel, I think there are several tools that segment the lesions on T2 in a similar way as we use it in MS. And the problem with these segmentation tools is that when you use some academic tools that are extremely or relatively robust, they are not very friendly. It takes some time. You have to export the images. You have to upload. Usually these academic tools are cheap or even completely free, but they are robust. But if you try to use some commercial tools, which are extremely easy to use, you just have to click a button. The main problem is that they are expensive, and secondly, that they are not always robust. So you have to have a balance. So that's why I think it's not easy to implement these tools in clinical practice. So I think that in the near future, and I am aware that the big MRI vendors, I'm talking about General Electric, Philips, or Siemens, they understand our need to use these tools, and that's why they are starting to implement robust tools that segment and quantify the lesions inside the machines. And this facilitates the use of these tools in clinical practice. I am aware that Philips has tools that are already available. Siemens has a prototype. I show you an example in my presentation that will be commercially available very soon. And I'm not familiar with GE. I never worked with GE, with General Electric, but I'm pretty sure that they also will provide the users with some tools. So I think that in the near future, we will have tools available in clinical practice.
Yeah. If you allow me, if I can mail you to send me some of these robust tools you are using in the research, because we are much interested in this small vessel disease quantification.
Yeah, sure. If you send me, you have my email. Just send me an email, and I can provide you with all the information you need, and you can share with your colleagues. Thank you.
I guess I can see more questions. So if this is the case, finally, we are honored and pleasured, of course, to have you with us this evening. And I hope you can share the next wave also to be with us. And hopefully next time you will be physically. I know. I guess, yes, you were with us last time with the Magnums.
Yeah, I visited you in Cairo and also to the south of the country a couple of years ago before the pandemic. And it was a real great experience. It was my first time in Egypt. I am really looking forward to come back, particularly because you have now the new museum, and also to meet all of you. And I think that to have face-to-face meetings also is easier to share the knowledge that you have and we have together.
We have the Cairo Neurology Conference in next February. Hopefully we can have you with us in this event if it's possible. Okay. So finally, it's our dear colleagues and attendees. We thank again Professor Alex, and we close the session, and hope for all of you to have a good night. Bye-bye, everybody.
Bye. Thank you.